Dr. Parashar has not joined.
Yeah, I'm just calling him. Do you want to test your slides, sir?
Yeah, can you enable me?
Oh, yes. Good evening, sir. Hi. I'm very right. Okay. Yeah, we can see the slides.
और क्या चल रहा है things in Bangalore?
अभी तो यहाँ पे पूरा बारिश है.
So you are doing ultrasound in your hospital or you have an ultrasound in your clinic? कैसे?
हाँ, I was doing it in both places. I had access to the radiology department in what was previously Columbia, now it's Manipal.
Yes.
And I had my own ultrasound as well.
Okay.
So, Joe has also joined.
Hi, Joe.
I have to unmute him.
Yeah.
Hi, Red sir. How are you, sir?
Hi, Joe. How are you?
I'm good.
Wonderful. Chalo, so Joe is now also he's ULAR certified.
Yeah, he told me.
Great.
But
So where was the advanced course and where was the exam?
Denmark with the ULAR this conference.
Great. So abhi be the same format, that same you have to get station, the same thing.
Same, sir. Everything is same. Nothing. Same team. Same people. All.
Anna Maria and Naredo and the three musketeers.
Yes.
Naredo, Anna Maria and Antonio.
Ingrid and all these things, sir.
Ingrid is very nice. Ingrid is very nice.
She's nice.
Very nice. The most difficult of them is Naredo, Anna Maria, Ianako, and this what's her name? Antonio, Mario Antonia, the French lady.
Okay.
Forgetting her name.
I can't remember any names or pronounce it. All are extremely tough names.
All tough names. Maria Agostino.
Okay.
Antoniette, yeah. She's led the OMERAC definitions for enthesitis.
This time, I think the Martolni, he also came in for a talk.
Martolni was there? Okay.
Was there for a talk.
Achha. And who all were the instructors there?
All, I think so many of them. There were, I think, 10 batches. So this time it was a big crowd because it has not happened for the last 2 years.
Yes.
So the crowd was quite big.
Sure, good. So you also have an ultrasound now with you in your hospital? And
I have my clinic.
My clinic also. Yeah.
That's all.
Which machine you are having?
This one, Logic Key from GE.
GE is always the best. I have BPL. Which one do you have, Dr. Sharath?
Sir, mine is also GE Logic.
GE Logic. And GE ka images is really good.
Really good.
Any images, no?
The reason I went for it is mainly for the after-sales service.
I didn't go for it because of the after-sales service. People here in North told me that GE doesn't give a very good after-sales service. They are always busy with the radiologist. So in that case, let me. So BPL ka lekin after-sales service is quite good.
Oh, is it? Okay.
Sir, even GE, the service is very good. I never had a problem for the last 4 years.
Oh, excellent.
There was no issues. They were always immediately called, same day they'll come in. And the images are spectacular. And not this one. I was seeing the newer machines. Spectacular.
Newer ones are very good.
Images are very good. I don't think if you compare to all the other these things, machines, G is the best imaging this one.
Yeah, amongst all the machines, I think GEs are the best.
G is the best. Wherever you go for the conference, all machines is there. Finally, when you see G, you know it is G.
Yes, yes, yes.
So, Dr. Sharath, what am I supposed to do? Any ideas? Somebody, Dr.
Yeah, so basically,
if some questions are there, so I need to ask, right?
Correct. You just need to, so.
And I think sharing is done by, hello?
Yeah, Dr. Parasar is supposed to log on.
Yeah.
I thought he logged on.
So he will share the session. I need to just, if some questions are there, I need to ask, right?
Yeah.
Yeah. Okay.
Just asking to unmute.
You should also start preparing the curriculum also. Yeah.
We need Dr. Parasar Ghosh.
Again, I think cannot start screen share but other parts. Okay, sorry. Yeah.
I'll just call sir 1 second.
So do you people see a lot of psoriatic arthritis and all in your practice, and do you do ultrasound in them?
I do.
Okay. And do you pick up psoriatic arthritis on an ultrasound when there is absolutely no evidence of psoriasis anywhere in the person or family or anywhere?
Only in like when there has been Dr. Parasar has joined. So only in situations where I'm able to pick up enthesitis, there I've been able to make that.
But then how would you differentiate
confidently?
But how would you then say this is not other seronegative spondyloarthritis? How come it is psoriatic arthritis?
So that is why I'm waiting for your talk. So I think people have already started to join in. Dr. Joe Thomas, there might be questions on the YouTube. It's being live streamed on YouTube as well. So if there are any questions over there, I'll put it in the chat box, and you can take that up at the end. Try to avoid muting yourself because I will have to unmute you if by chance you get muted. Dr. Parasar, are you able to hear us?
Yeah. Can you hear me?
Yes, we can hear you.
Yeah, Parasar. Hi, how are you?
Good evening. So how you are managing? There will be questions will be asked in the chat box.
Yes, I'll put the questions in the chat box, and Joe will take that up at the end. And initially, I think we have one. Oh, we have already. It's already 8:30. So I think we'll start off, Dr. Parasar. So welcome everyone to the latest meeting of the Musculoskeletal Ultrasound Special Interest Group. Today we have a very interesting topic on psoriatic arthritis, which will be moderated by Dr. Joe Thomas. Dr. Joe Thomas is known to all of us. He is a rheumatologist with wide experience, particularly in X-ray. He had a very nice session he took for us during the COVID lockdown. The meeting will be chaired by Dr. Parasar Ghosh, who is one of the prominent rheumatologists in Kolkata. And of course, the main speaker will be Dr. P.D. Rath. Over to Dr. Parasar Ghosh.
A very good evening to all of you. So today, Dr. Rath does not need any introduction, but still, when I going through his short CV, I was finding I did not know many things actually. So see, he needs introduction. You should know that P.D. Rath is the first ULTRA certified ultrasonologist. Or what should I say? Is that the right term? The Rath is the first. I think you are the only one. I think anybody else is there.
No, the first, because now Joe has become the second. Joe has also become
second. So
yes.
Now we have second now. So and also he had got diploma in musculoskeletal ultrasound from Spain. So the topic he is speaking basically he is an authority. I can tell you he has an authority to speak on this. He had been the member of the executive committee of the IRA a number of times, and presently he is a member of the Delhi IRA also, Delhi branch of IRA also. He had many publications, international, But the thing to remember is that P.T. Roth has got special interest in musculoskeletal ultrasonography, and he's a ULR certified. He has done through all the phases. Basic, many have done. I have also done basic. But intermediate and advanced courses, very few of them, and he has done all those things. So, what to Dr. Roth?
Thank you, Dr. Parashar. Thank you, Sharath, and welcome, folks. So today I'm going to talk about ultrasound in psoriatic arthritis, what every rheumatologist needs to know. And let me go back and start from the beginning to set the base. So we all know that the CASPER criteria, which came out way back in 2006, actually really defined psoriatic arthritis. And it defined psoriatic arthritis as an inflammatory articular disease, which was either joint or spine or enthesis. So any one of these could be psoriatic arthritis. So with this, you should either have had an evidence of current psoriasis, a personal history of psoriasis, or a family history of psoriasis. So even if the person does not have psoriasis and there's a family history, you could still classify them as psoriatic arthritis. Of course, if you have nail dystrophy is very important. Other important thing is that the absence of rheumatoid factor gives you 1 point, but the presence of rheumatoid factor does not exclude psoriatic arthritis. So that's another very important thing to remember. So dactylitis and radiographic changes. And we know that radiographic changes happen quite late. So basically psoriatic arthritis is basically nothing but a peripheral arthritis with dactylitis or without dactylitis, or it could present as enthesitis or axial spondylitis in a patient who has had psoriasis, or there's a family history of psoriasis in a first or second degree relative. Rheumatoid factor may be positive or negative, it does not matter anymore. So arthritis in the presence of overt psoriasis is not a big deal. I mean, it's not a big deal that the person comes with frank psoriasis and has arthritis. We make a diagnosis of psoriatic arthritis. We don't need an ultrasound to make a diagnosis in these patients. However, in patients who don't have overt psoriasis, we look for occult psoriasis. And this should be a practice for all youngsters, looking behind the ears, antenatal cleft, on the nails. So occult psoriasis becomes very important. So always look for occult psoriasis in the absence of overt psoriasis, right? So we know that CASPER criteria also talks about psoriatic arthritis without psoriasis. So a person may not have psoriasis, but a first or second degree relative in the family may have psoriasis. So then how to recognize psoriatic arthritis in the absence of overt psoriasis, which is psoriatic arthritis sign psoriasis. And just a small teaser. So which of these paintings is by Picasso? And this is one of my favorite slides. If anyone can maybe take a guess, one of you could take a guess.
D. I would say D.
D. So Sharath already knows. So basically, when you see Picasso painting, Picasso was a cubist artist. So he would basically, the objects would be analyzed, broken up in cubism and reassembled in an abstract form. So when you see that, even if the name of Picasso is not there, by the pattern of that painting, this is Picasso. And this is what is clinical medicine. Clinical medicine is nothing but pattern recognition. So we know that psoriatic arthritis has different patterns. It can present as a polyarticular disease. It can present as an oligoarticular disease. So I'm not going to talk about all that, but today I'm going to talk about how can ultrasound help make a diagnosis of psoriatic arthritis in the absence of psoriasis. So if psoriasis is there, or there is a family history, or there is an occult psoriasis, I'm sure we are all good clinicians and we always make a diagnosis of psoriatic arthritis clinically. But sometimes when there is absolutely no clue, there is no clue to a history of psoriasis, there is no occult psoriasis, there is no family history of psoriasis. Can you, by doing an ultrasound in a patient with pure so-called seronegative arthritis, tell with some probability or surety that this is probably a patient with psoriatic arthritis? And that would be my talk today. And I start with this paper by the Italian group, how to differentiate between early rheumatoid and early psoriatic arthritis by the ultrasonographic study of the synovial complex of the small joints of the hands. And basically, if you look at the ultrasound findings in, say, psoriatic arthritis, early rheumatoid arthritis patient versus an early psoriatic arthritis patient, what you find are certain things which are significantly higher in psoriatic arthritis patients as compared to early rheumatoid patients. So PTI, or peri-extensor tendon inflammation, also known as PARATENONITIS, because we know that the extensor tendons of the hands do not have a tendon sheath. So if you have an inflammation around this tenon, or a paratenon, which is called, it's called a paratenonitis. And if you see you can see that in early psoriatic, this is significantly higher, 54% versus only 2.5% in rheumatoid. And similarly, if you have power Doppler in the peritendinous area or paratenonitis, again, very highly seen in psoriatic arthritis, not seen in rheumatoid arthritis. The other thing is CSE or central slip enthesitis. And I'll come to each of these and I'll show you some images. So when you look at a central slip enthesitis in the hands, again, you find it significantly higher in psoriatic than in rheumatoid. And again, a power Doppler of the central slip is again significantly higher in psoriatic as compared to rheumatoid. It's almost 21.4%, 25% compared to 0%. And then soft tissue edema, mostly clinically involving the fingers. This is seen again in very high percentages in psoriatic arthritis, 42.3% versus almost 2.9% in rheumatoid arthritis. Now, when we talk of sensitivity, specificity, or positive predictive value, so we need to know what is the positive predictive value of these tests. So let's look at the positive predictive value of a paratenonitis or a peritendinous inflammation. It's 92.9%. So when you're looking at PTI, your PPV or positive predictive value is 92.9%. And if there is associated power Doppler, it's the same. When you're looking at a central slip enthesitis, your positive predictive value is 100%. So if you get a central slip enthesitis on ultrasound, you know for sure you're talking about a patient of psoriatic arthritis, even if the patient has absolutely no findings, no history, no family history. And if you have a power Doppler of the central slip enthesis, then you again have a positive predictive value of 100%. If you have a lot of soft tissue edema in the fingers, and I'll show you some images, this is a 91.7% positive predictive value for diagnosis of psoriatic arthritis. We know there are 5 targets in psoriatic arthritis. So the joints, the tendons, the enthesis, the skin, and the nails. So when we look at joints, so let me show you a joint in rheumatoid. Now, this is a very classical. So if you see a classical rheumatoid joint, you can see the very nicely demarcated cortex. You can see the MCP joint. You see the power Doppler there, and you see the extensor tendon, thin slip of extensor tendon passing over. And if you look at the overlying dermis and the epidermis, they're all normal, right? So this is a classical synovitis. This is again a synovitis at the MCP joint, and you see the extensor tendon going above, and you see the dermis and the epidermis very normal. Compare this with psoriatic arthritis, and you see not only synovitis, and if you see this extensor tendon here, thin slip, there's also a lot of edema around this extensor tendon and going right up till the skin. And this is very typical of psoriatic arthritis. So you can have an exudative form and a proliferative form. This is again an image, and I'll show you. So this is the MCP joint, metacarpal head, and the phalanx. And you see the synovitis here. But what is more important is look at the extensor slip of tendon and look at the peritendinous inflammation. And look at the edema of the dermis and the overlying skin. And when you look at the power Doppler, unlike rheumatoid, there is no respect to the boundary. So the Doppler goes right into the soft tissue, peritendinous area, and up to the skin surface. This finding is very, very typical in psoriatic arthritis. Wrist, of course, we know is involved, not much difference there. Sternoclavicular joints can be involved. The DIP joint, of course, we know is very, very typical, but sometimes there is a lot of difficulty clinically to differentiate a psoriatic from an osteo. And that at times can be difficult, and an ultrasound can really help pick up the soft tissue edema, which is so typical of the inflammation around the DIP joint. Now, when we come to shoulder, again, the AC joint somehow is the most common joint involved in shoulder in psoriatic arthritis, in contrast to the glenohumeral joint, which is seen in rheumatoid arthritis. And this is again a paper I'm quoting. So they looked at many shoulders in psoriatic arthritis patients, and they found glenohumeral arthritis in only 4 out of these 194 joints. But they found that the AC joint was very frequently involved, hypertrophy in 40%, synovitis in 27%, and osteophytes in 26%. So if you have a patient of shoulder pain who has an isolated AC joint involvement, and you have no other features suggestive of rheumatoid, and this is a seronegative patient, you should have a very high suspicion of psoriatic arthritis when predominantly the AC joint is involved in the shoulder. Now let's come to the tendons. Now this is a flexor tendon, and we see that there is these anechoic areas around the flexor tendon, and you see the power Doppler. So this is a very classical flexor tenosynovitis, and this is a patient of rheumatoid arthritis. Now contrast that with a patient of psoriatic arthritis. So again, what you see is not only is there involvement of the tendon sheath, but there is a lot of surrounding edema of the soft tissues. And the soft tissue edema goes right up to the skin surface. And when you look at the Doppler, it's not limited, unlike rheumatoid, which respects the boundary. This goes right up to the skin. So this kind of soft tissue edemas and lot of power Doppler extending up to the skin surface is again what differentiates a psoriatic tenosynovitis from a rheumatoid tenosynovitis. And dactylitis is nothing but a combination of flexor tenosynovitis, a lot of soft tissue edema, underlying synovitis, and paratenonitis of the extensor tendon. So when you get all of these, you're probably talking of dactylitis. So what is this peritendinous inflammation? So you can see again, this is an extensor tendon, and you see a lot of peritendon inflammation. So as you know that the extensor tendons do not have a tendon sheath, unlike the flexor tendons, which have a tendon sheath. So when you get a tenosynovitis in the flexor tendons, you do not get a tenosynovitis per se in the extensor tendon. But what you do get is something known as paratenonitis or peritendinous inflammation. And this peritendinous inflammation, whenever you see in a hand, is very classical of psoriatic arthritis. So again, I will show you some images. So this is again the MCP joint, and this is the extensor tendon. And look at this image, and you see the peritendinous edema, inflammation, power Doppler in long axis, edema going right up to the skin. This is again the short axis view of the extensor tendon, and just look at the amount of edema surrounding the extensor tendon. So this is a view which is very, very useful view. And this is a view which I'll show you later, which I learned from Professor John George. Is one of the best ways of screening a hand is not, so the EULAR teaches us the long axis, but the long axis has its own problems. And the problem is in long axis, you need to screen right from one edge to the other, because very often the inflammation goes, the edema or the fluid always trickles down or gravitates down. So the short axis view is one of the best views. So this is an extensor tendon again, and you see the paratenonitis. So please learn to appreciate this paratenonitis of the thin slip of extensor tendon, which is so typical. Paratenonitis of the Achilles tendon. Again, Achilles tendon is again a tendon which has no tendon sheath. So when you get edema, a peritendinous edema around this tendon, this is known as paratenonitis. And again, you see a lot of edema of the overlying dermis and the epidermis. This is again a very typical finding seen in psoriatic arthritis. Now, enthesitis is another thing, but we know that enthesitis is not unique to psoriatic arthritis. It is seen in almost the entire group of spondyloarthritis, whether you talk of reactive arthritis, whether you talk of IBD associated, whether you talk of ankylosing. And this is a classical Achilles tendon showing enthesitis. A word about enthesitis, which I learned from Professor Mario Agostino, is unlike the joints, when you're looking at the enthesis, the leg has to be very relaxed. It should not be taut, should not be neither dorsiflex nor plantar flex in neutral position, hanging. Apply a lot of jelly, because enthesitis, the Doppler is very subtle and it takes time to pick it up. And wait for a substantial period of time for the Doppler to appear. Unlike the MCP, the other joints where you just put the ultrasound probe and you get the Doppler, in an enthesis, you must wait for some time because the tendons are stretched. They will relax, and then the Doppler will appear after a few seconds. So you need to wait patiently for a few seconds or even longer for a power Doppler to appear at an enthesis. Otherwise, you would falsely call it normal. You must wait. I mean, 10 to 15 seconds, you need to wait almost to see a power Doppler sometimes. So we know that you can get erosive enthesitis. Even that may not be specific for psoriatic arthritis. This is again, you can see the lateral epicondyle and the common extensor tendon origin, and you get power Doppler there. So what we all know today is that if the Doppler is within 2 mm of the bone, it becomes quite specific for enthesitis. And for those of you who would want to know how to differentiate a degenerative enthesopathy from an inflammatory enthesitis, the BUSIS criteria, which is I think an Hungarian criteria, is one of the best criteria to differentiate. A score of more than 7 tells you this is inflammatory enthesitis, and a score of less than 7 probably differentiates it from a DA, because we know that even in degenerative enthesopathy, you can get power Doppler, but the Doppler is not within 2 mm of the bone. Again, plantar fascia, you get thickening. So this could be a feature of enthesitis. But what is so unique about psoriatic arthritis is the microenthesitis. So what is microenthesitis? Is enthesitis happening in the fingers. So a capsular enthesophyte, a basically soft tissue thickenings, insertional tendinosis of the DIP, extensor tendon of the DIP. These are all very typical, which are known as microenthesitis. So here is a calcification happening, a capsular calcification at the DIP joint, which tells you that this probably is a patient of psoriatic arthritis. This is calcification of the extensor tendon near its attachment. Again, this tells you this could be an early microenthesitis. And these findings are very typical of psoriatic. Now let's look at the DIP joint. So here you find an enthesophyte, and this is the tendon coming and attaching here. And when you look at the power Doppler, you can see the enthesitis, the microenthesitis happening at the insertion of the extensor tendon into the distal interphalangeal joint. Again, this is a patient of psoriatic arthritis, and this is the DIP joint. And you see the extensor tendon, and you see the peritendinous edema. Look at the soft tissue edema and look at the enthesitis. And this is an enthesophyte. This is nothing but an enthesophyte. So any step-up deformity at the end or at the site of an insertion of a tendon or ligament is an enthesophyte. So you have an enthesophyte, you have erosions, you have power Doppler, and you have soft tissue edema. Very classical of psoriatic arthritis. Now, what is central slip enthesitis? And before I go to that, just to give a brief recall, we know that the central slip of the extensor tendon attaches to the middle phalanx. So when you look at the central slip, this is the central slip attaching to the middle phalanx. If you get central slip edema, so this is a central slip edema, or with and without, if you get power Doppler around the central slip, this is again has almost 100% positive predictive value for psoriatic arthritis. So when you're looking at the hands, look for these microenthesitis, look for these peritendinous inflammations, look for the central slip enthesitis. So the central slip insertion, at the site of insertion, there is enthesitis. So these are all called microenthesitis. You can see the edema of the central slip at the insertion. Soft tissue thickening. Soft tissue thickening of the finger pads is again something, this is again a volar view. So you can see a palmar view, and soft tissue thickening of around the flexor tendon is again something which is very, very typically seen in long-standing psoriatic arthritis. So a lot of soft tissue edema around the finger pads. So again, a very wonderful article by Dr. Gurjeet Kelly, importance of ultrasound in identifying and differentiating patients with early inflammatory arthritis. He has pointed out again a very important sign. He talks about palmar plate inflammation as a very important sign in psoriatic arthritis. So there's a flexor tendon, this is the palmar plate, and this is the metacarpal head. So inflammation of this palmar plate is again something typically or peculiarly seen in psoriatic arthritis patients. The other thing is collateral ligament enthesitis of the fingers. So this is the view which I was talking about, which I learned from Professor John George, is the short axis view. So when you're looking at the short axis view, let me just briefly show you the anatomy. Okay. So you see the bone as a wedge shaped, not wedge, I would call it a kind of N-shaped deformity, N-shaped configuration. And on the sides of this, you get the collateral ligaments. So if you look at the metacarpal, this is the metacarpal head. This, of course, probably is an erosion, not erosion, a dip, sorry. And when you look at the radial side, you see the collateral ligament. So when you look at collateral ligament enthesitis, edema, and Doppler, this could again be a sign of microenthesitis. So here you see edema around the collateral ligament of the fingers. So one of the best views is to start scanning and look for the radial collateral ligament. So that's the view you can see. The other thing, of course, is the periosteal reaction, which classically we see in fractures. But when you see a lot of periosteal reactions or periosteitis or fuzzy bone in a patient, and especially if you're looking at, say, a bony prominence like, say, at the site of enthesitis, or sometimes you see it at the medial malleolus, you really are looking at psoriatic arthritis, because this is periosteal reaction. On the ultrasound, it looks like a lot of fuzzy bone, what I call it. The other finding, of course, is the fifth metatarsal bone bursitis. Now, this is the fifth metatarsal bone bursitis. And this is again a very elegant paper by Giovanni and colleagues, where they've looked at involvement of the bursa of the fifth metatarsal joint in psoriatic arthritis. And when they've compared this psoriatic arthritis patients with healthy controls and spondyloarthritis patients, they found clinical evidence of this bursitis only in psoriatic arthritis patients. They have had no evidence of this bursitis in either healthy controls or in spondyloarthritis patients. So the clinical evidence, the ultrasound evidence, or the clinical plus ultrasound evidence seems to be very peculiar for psoriatic arthritis. So this is again an ultrasound of the fifth metatarsal bursitis. Bursa, this is the short axis and this is the long axis view. So if you're getting a fifth metatarsal bursitis, either clinically or on the ultrasound, you're probably talking of psoriatic arthritis. The other important and fascinating thing is thickening of the flexor tendon pulleys. Now, this is again a very useful ultrasonographic sign in the diagnosis of psoriatic arthritis. And I remember when I did my fellowship way back, and I did this the pediatric course from Australia. So that time I remember Dr. Prue Manus talking to us about dry synovitis. There was something called as dry synovitis, where a person would just have the fingers flexed, unable to extend, unable to flex, and there was absolutely no synovitis. We know now that that probably was psoriatic arthritis, and we do see a lot of patients. So just to recall a recap, that's the metacarpal head, this is the tendon, and this is the A1 pulley. So if you look at the metacarpal head and you look at the flexor tendon, you look at the A1 pulley. Normally the A1 pulley is not very visible. It casts a very small shadow, not a very big acoustic shadow. But when this pulley is thickened, this casts a significant shadow on both sides of the tendon. And you can see the thickening of the pulley. So just the thickening of the pulley can be the only sign of psoriatic arthritis. So many of the patients who present with so-called trigger fingers, who are not diabetics, could be psoriatic arthritis patients. If you scan their A1 pulley and you look for thickening, and a lot of these patients come with these flexed fingers, dry synovitis, which was earlier called, probably is nothing but thickening of A1 pulley. And when you look at the thickening of A1 pulley in patients of psoriatic arthritis, as compared to rheumatoid, undifferentiated, and other diseases, you find very typically seen in psoriatic arthritis patients, very typically seen. So this is again another sign. So I think these are some of the subtle signs which are very important to pick up psoriatic arthritis. And when I see these signs on ultrasound, I know I'm dealing with a patient of psoriatic arthritis, even if the patient has no history of psoriasis whatsoever. Now, this is a paper where they compared ultrasound, MRI imaging, and radiography of fingers in patients of psoriatic arthritis. So you can see that on the MRI, when you get synovitis, on ultrasound, you can see synovitis very nicely. Extensor paratenonitis on the MRI can be seen on ultrasound very, very nicely. And we know that tendons can be visualized, and these microentheses can be visualized on the ultrasound far, 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 far better than MRI. So this is a flexor tenosynovitis, bone erosions, and finally we can see bone proliferation, or what we call the periosteal reactions or periosteitis or fuzzy bones. So they showed that there was an excellent agreement of ultrasound with MRI when it came to synovitis, paratenonitis, flexor tenosynovitis, erosions. But what was very important is when it came to bone proliferation, an ultrasound scored over MRI. So ultrasound was superior for detection of bony proliferation to MRI. So this is very fantastic thing. So ultrasound clearly is a beautiful thing. Now I'll come to the skin briefly. When you see a patient of psoriasiform lesion, sometimes we wonder whether this is psoriasis, whether this is psoriatic, whether this is a subacute cutaneous lupus psoriasiform rash, or whether it's a dermatomyositis. So sometimes an ultrasound may help, and you can see the clear thickening of the epidermis compared in a psoriatic skin compared to a normal skin, and there's a lot of dermal edema. with power Doppler. And so much so that the epidermis can get so thickened, it actually can give an acoustic shadowing. So again, you see a lot of dermal edema in these plaques. The epidermis is classically thickened compared to the normal intervening skin. Sometimes there is a separation, and this can be an anechoic area separating the epidermis from the dermis. There is dermal edema and Doppler signals in the dermis. And finally, the nail, which itself is a whole book, there's a lot of things in detail. But if you look at the nail plate and the nail bed, normally the nail bed has few vascularity, but the nail plate is very sharp, shiny with a classical trilaminar pattern. Now this pattern is of course lost in psoriatic arthritis. It becomes thickened, the nail bed is thickened, and there's a lot of very severe power Doppler, much more than normal in the nail bed. So this is one of the psoriatic nails, and this is again a short axis view of the same. So it's very important to recognize these findings that in patients who do not have psoriasis, who have no family history of psoriasis, if you pick up microenthesitis in the hands, if you're picking up peritendinous inflammation, paratenonitis, if you're picking up central slip enthesitis, if you're picking a lot of soft tissue edema in a flexor tendon, tenosynovitis going right up till the skin surface, if you're picking up a fifth metatarsal bursitis, if you're picking up a thickening of A1 pulley in a person who has no other explanation for such a finding, and if you pick up things like capsular calcifications, enthesophytes at the insertion of the extensor tendon into the in the fingers, then you're probably talking of psoriatic arthritis. And finally, we know, of course, that from a patient of psoriasis to psoriatic arthritis, again, a wonderful paper I thought by Saurav Malviya, one of our friends and colleagues. And what we know now is that patients of psoriasis who have these microenthesitis, who have asymptomatic enthesitis, also are at a very high risk of developing into psoriatic arthritis. So I hope with that, I have added something and will help you in your day-to-day practice. Thank you.
Thank you, Rath sir. As usual, a lucid talk. So I'll just start with the question in the chat box. Are there any differentiating features between enthesitis in spondyloarthritis versus that seen in psoriatic arthritis?
Yeah, so major enthesis, probably no difference, but microenthesitis is what is the key. And if you're looking at microenthesitis in the hands, as I showed you, paratenonitis, peritendinous inflammation, central slip edema, central slip enthesitis, these are very typically seen in psoriatic arthritis amongst the spondyloarthritis.
The next question is that isn't the first MTP erosion feature of RA and a part of ultrasound score? Should we also think of PSA also? That's the question.
Yeah, that's true. I mean, MTP erosion is different. I'm talking of a bursitis. Now, I'm not talking of a erosion in the joint. I'm just talking of a bursitis. So bursitis is very typical of psoriatic arthritis. Erosion can happen in any erosive arthritis, whether you talk of psoriatic or you talk of rheumatoid arthritis.
Okay. I think the next question was, 1 second, sir. Ultrasound of the hip joint. That is one question has been asked about. I don't know whether it's specific to psoriatic arthritis. The question says ultrasound in hip joint. That's all.
Ultrasound of hip joint. Well, I mean, that's not specific for psoriatic arthritis for sure.
And so is there any difference in enthesitis between spondyloarthritis and gout? That's another question.
Gout, I don't think you get enthesitis. Gout, it's more of the tophi, which is always extra-articular, subarticular, which is causing the inflammation. It's almost like a tumor eroding into the bone. So when you see the ultrasound, you can see the tophi and how nicely it erodes into the bone.
The next question is role of ultrasound for sacroiliac detection in psoriatic patients.
The ultrasound has its limitations because when you come to bony cortex, the ultrasound beams reflect back. And that is the reason sometimes when you're looking at the spine, it's very difficult to do ultrasound of the spine. Though I can admit that I do a bit of ultrasound of the spine, but I do that mainly for interventions and that too for facet joint injections. And that too, when the C-arm is not available to me. So I use it, I do, but it's not very difficult, but it has its own limitation. But you cannot visualize the sacroiliac joint on the ultrasound, but you can inject the sacroiliac joint on the ultrasound. But you can't look for power Doppler or synovitis or anything like that, or even an enthesitis. It's extremely difficult.
I think the again question related to the fifth metatarsal bursitis is very specific for psoriatic arthritis.
I showed you that compared to healthy controls and other spondyloarthritis, it's not seen at all. So that probably makes it quite specific.
I think are the microentheses asymptomatic? That's another question. That
can be. If they are in a patient of psoriasis, these are the highest risk factors for these patients to develop into frank psoriatic arthritis.
And how to differentiate erosion from DAP joint on ultrasound? So probably from a how to identify DAP erosion in an ultrasound. That's probably the question.
I think Joe, you should also as well answer how to what are the ultrasound definition of an erosion from a
I think if you ask me the definition, I'm also.
It's basically like a step down deformity. So any step down deformity is an erosion, and any step up deformity could either be an osteophyte or an enthesophyte. So if you're looking at the end of a joint, it's an osteophyte. If you're looking at the end of an enthesis, it's an enthesophyte. It's as simple as that.
And you have to identify it in two planes, both short axis and long axis.
Very important. Always identify in two planes.
And the next question from Dr. Sharad Chandra Mauli sir was best imaging technique for enthesitis.
Well, ultrasound any day. See, because what happens is, if you look at the enthesis, the cartilaginous part, it has very less fluid in it. And because of the less fluid, an MRI is not a good modality to pick up, because MRI picks up best where there's a lot of fluid. So that's why that makes ultrasound a far better imaging for an enthesitis than an ultrasound, than an MRI. So I feel that ultrasound probably is one of the best imaging techniques.
Yeah, and probably multiple entheses can be screened at one go.
Yes.
Which is a better, rather than in MRI, you're stuck to one joint. At a time, we can do different MRI. I think there was one more question. Is tuft erosions are pathognomic of psoriatic arthritis?
No, tuft erosions can be seen in lot. If you see the Resnick chapter on tuft erosions, there are so many conditions where you can get tuft erosions, starting from a guitar player to sclerodermas to, your psoriatics, a lot of things. Hajdi syndrome, there are a lot of things. So there's a huge list. You can go to Resnick and read the chapter, and there's fantastic differential diagnosis.
The next question is 52-year-old lady with tenosynovitis, stringer fingers due to pulley thickening, seronegative but hypothyroid. Should we suspect psoriatic arthritis?
So hypothyroid itself can also cause these kind of findings. But if you feel that the hypothyroid is not very significant and you're getting it in multiple joints, you must ask these patients very meticulously to find out if they have a family history of psoriasis.
I think the commonest what we see is in diabetes, where we get multiple.
So the most common trigger is diabetic. But when you see a person who's not diabetic, when you see a person who doesn't have any explanation for these trigger fingers, this finding is so very now typically of psoriatic. So I used to get these patients who used to come like this, they can't flex, they can't extend. It's what we used to call dry synovitis. And they would come with this kind of a hand. And when you palpate, there's nothing but diffuse thickening of the A1 pulley. These are the psoriatics.
So is there any, when you see a pulley thickening, you should scan for other joints just to see if there is any?
Yes.
That's something you do?
Yes. So when you see the A1 thickening and you're suspecting a psoriatic, you should start looking for everything clinically, ultrasonologically, historically, any clue to any other area or part of the body which has either psoriasis or an enthesitis. So you would pick it up.
The images were fantastic, sir. But how easy is it to do it on a routine practice?
It is very easy, and on the G machine it is fantastic. I could not upload the video. Recently we did, and one of my students had recorded a video. I'll probably share it on the group. Very nicely we'll show you the entire peritendinous inflammation. It picks up. You have to put a lot of jelly there and just float the probe, and you will see this. You will see this peritendinous inflammation, peritendinous edema. It's very, very typical.
So you have a hockey stick probe or a?
I have a hockey stick probe, but believe me, even with a normal linear probe, you can see it. Any 12 to 12 is enough to pick it up, though we use the 15 one. But I think even on 12, it's not very difficult. You will pick it up. It's not very difficult. It's just that the moment you start looking, many times what we do is we just look at the flexor tendons and the MCPs. We don't look at the extensor tendons per se. So I'll do is I'll share the video on the group. recently and some images which we took of our psoriatic arthritis patient. Very classical he had findings. We'll share that. I'll share that.
There was other few more questions. Is A1 pulley specific for psoriatic, or it can be any pulley?
No, it's not specific, but this particular paper highlighted the fact that if you have a thickening of A1 pulley in a non-diabetic, non-hypothyroid, psoriatic becomes one of the important differential diagnoses. Let me put it like that. It should come to one's mind.
Yeah. The next question is, do you prefer injecting pulleys in bothersome trigger fingers in both inflammatory and non-inflammatory conditions?
Oh, absolutely. Absolutely. Trigger finger injections are something we all do routinely. Every day we are doing 5 or 6. Whether inflammatory, diabetics in fact are the most common that we inject much more than any others and much more amenable. So yeah, we do. And I do it both blind and ultrasound. I mean, the thicker ones, some of them are very thick, and then you need to do it under ultrasound because you can inject. So I can say I have injected up to 40 milligram of steroids in a flexor tendon going under the A1 pulley under ultrasound guidance. But when I'm giving a blind, only 10 mg. You don't dare to give more than 10 mg of steroid in a pulley. But under ultrasound guidance, when you just below the pulley and you're in the flexor tendon sheath, you push 40. I've done that. That's what I'm saying. Nothing happens. But you have to be very sure you are in the tendon sheath.
Absolutely. With so much of volume, I think that is something which we. And I think PSR Gupta sir wants to ask, is there hip joint erosions in psoriatic arthritis? I think that's what he meant earlier also, hip joint erosions.
No, not specific for psoriatic, not specific. These are the only things, these are the only things which will make you think of psoriatic arthritis. Paratenoitis is classical, and now we've been doing this for a long time now. I've been doing this for almost, I don't know how many years, 8-9 years. We're picking up paratenoitis, picking up these microenthesitis, picking up the central slip edema. This is very, very classical.
And Dr. Sanjana wanted to know how you detect bone marrow, bone proliferation on ultrasound.
So bone proliferation ultrasound is a very fuzzy looking bone. So if you look at the ultrasound image of the cortex, it's a very sharp demarcated line. If you've seen a fracture, I don't know ever if you've seen a stress fracture on ultrasound, it's a very kind of fuzzy, irregular bone. So the cortex becomes very irregular. And I tell you, sometimes these things are found only on the medial malleolus. And Dr. Guji told me a very fascinating thing. He told me that this is a kind of enthesitis, even though the PTT tendon is, branch is kind of not really inserting, but it sends fibers into the along the medial malleolus. So it's always a paraenthesitis rather than a true enthesitis. So true enthesitis is where the tendon goes and attaches into the bone. But if the bone is adjacent to a tendon, the tendon has some fibers going into the bone. So along the medial malleolus, when you have the PTT going on the side, you get periosteitis there. That's also a very fascinating finding. Yeah.
I think there have been a lot of questions. As usual, it was a fantabulous presentation. I think it's already 10 minutes past the time we've been allotted. So I think we'll expect more talks from you, sir, soon.
Thank you.
Again,
so I'll send this video, and I will now expect all of you to send one paratendinous inflammations in your practice. Believe me, you will find it so fascinating. The moment you pick up, you'll say, this is psoriatic arthritis. You don't need anything else. Okay.
Okay, sir. Thank you.
Bye. Thank you so much. Thank you all. Bye.